So today we're going to be discussing diabetes mellitus. There are two different types. Type 1 is autoimmune. It affects the beta cells within the pancreas, and those are the cells that are responsible for the secretion of insulin. Or there's type 2, which is insulin resistance due to decrease in beta cell insulin secretions. Type 2 is typically developed either because of obesity or inactivity. There can be some genetic familial links to that as well. And that's also accompanied typically with cardiovascular factors. Hyperlipidemia, so they have increased lipids within their bodies. Hypertension also, and increased clot formation, so their blood's a little bit too thick. So those go along with the type 2. When we're testing for diabetes, we're going to run a A1C or a glycosylated hemoglobin to measure glucose attachments to hemoglobin. Increased A1C is going to show if there's long-term hyperglycemia. So as the elevation in blood glucose remains, glucose will bind to proteins, so it'll bind to the hemoglobins within the blood. So the longer you have the hyperglycemia, the more the A1C is going to be elevated. So increased A1C shows long-term elevated blood glucose. So A1Cs at or greater than 6.5% is what they typically will diagnose diabetes at. So we can also do a fasting glucose. So no caloric intake for 8 hours before the before the test. They'll draw some blood and just get a glucose off of that. So that's run off of your plasma levels and not off of the bound glucose. So for that to diagnose, they like 2 tests at greater than 128. And if they're just going to do a casual, so not a fasting glucose, just a typical plasma glucose, they'll do over 200 if they have symptoms of hyperglycemia. So patients that have any of your classic hyperglycemia symptoms, so really like the increased thirst, decreased urines because their body is trying to retain as much water as it can to dilute all the sugars. So those are all of your hyperglycemia. So that over 200 can be used with symptomatic hyperglycemia, the casual plasma. And then islet cell antibodies can be used to diagnose type 1 because that will show breakdown of the pancreatic cells for the autoimmune disease, showing that your body's attacking your pancreas and causing the diabetes. Same thing with autoantibodies for insulin. And you can also check for C-peptides, which will look at pancreatic function. So decrease in those means either type 1 or late stage type 2. Different medications we can give. Of course, type 1 diabetics get insulin therapies because they are not producing insulin, so they have to have it supplemented. Type 2s can get insulin stimulators, so that means that they are there to stimulate the beta cells to produce more insulin. That is if they are still producing. And then insulin sensitizers. Sorry. So those will increase the cellular use of glucose to reduce the blood sugars. Those medications, some of them have black box warnings, which is just a severe contraindication or severe side effects of those drugs for heart-related illnesses, some macular edemas, and fracture risks with those. Just have to be really careful when you give those to your patients and make sure that they are able to combat those side effects and make sure you monitor for any of that. That's all those black box warnings do, is just let you know. You have to be really careful with those medications. Our patient, we can teach them to help manage their diabetes without or as supplements to the medications, not without the medications, but reducing their carbs and sugar intake through their diet. Just reducing the intake of sugars will help them manage their sugar. Exercise can help them as well, but you have to also be cautious with that, because if they exercise like right after taking their insulin, they can actually put themselves into hypoglycemia, so they can reduce their sugar too much. So either right before exercise they should reduce insulin intake, so if they'll just reduce the amount of insulin that they're going to use, or before they can also eat like just some carbs, just to give themselves the extra sugars to burn off. Type 2 diabetics, weight loss can be helpful as well. Some complications that are pretty common with diabetes is, of course, diabetic neuropathy. So they lose the sensation in their feet so that they can get injuries and they don't know about it. So make sure you always check your diabetic patients, like their legs and their feet, because it can also lead to the diabetic ulcers, which is just wounds on their feet that they didn't know were there because they can't feel them. So those can get pretty bad and can also lead to amputations. So that's always something you want to watch for. Also, retinopathy in your diabetic patients. Severe diabetes can damage the vessels in the retinas and lead to vision loss and changes, so make sure you monitor those as well. One of the most common that I deal with, at least at work, is DKA. So that is uncontrolled hyperglycemia, leads to metabolic acidosis, respiratory alkalosis, all kinds of bad things. So because of the metabolic acidosis and the uncontrolled glycemia, they produce ketones. So it's most common in type 1. It can occur in type 2 if they've gone through some kind of trauma. Real bad injuries, surgeries, all of that can lead to it in type 2s, but it's not nearly as common. Your classic symptoms, they have like a really, like a fruity smelling breath, vomiting, abdominal pain, dehydration, weakness, confusion, comas, death. So because of the ketones increase, the pH decreases, which is what causes your acidosis. And then you get the Kussmaul respirations, which are just these really, really rapid, deep breaths that they take, which cause their respiratory alkalosis to combat the acidosis to try to help even everything back out. But they will go on long-term insulin drips, and they need to be hospitalized to manage all of that. So they get long-term insulin drips, hourly ketone checks, blood sugar checks, until everything is controlled. So that is diabetes.